Hello, my name is Dr. Roger Henderson. I'm a GP in South West Scotland, and I also co-host the GPnotebook study groups. Welcome to this GPnotebook podcast, where we discuss bite-sized topics aimed at all those of us working in primary care. Now, you can find us on all major podcast platforms, including Spotify, Apple Podcasts, and Google Podcasts. So do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving us a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups, and you can find me there too at Roger the Doctor. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Now, talking about study group meetings, this topic I'm going to be talking about, which is obesity, is one of the topics we'll be looking at in greater detail in our Study Group 4 meetings, one of half a dozen meetings which we do throughout the year. And if you've seen us at those study group meetings, we hope you really enjoy them. And if you haven't caught us yet so far this year, then do book in later this year at a time to suit you. There really is something for everyone in them. Now, if we turn to obesity as a subject, the statistics are, I'm afraid, quite salutary. Almost 2/3 of adults in England are currently overweight or obese. About 26% of adults are obese, and about 38% or so are overweight. Even more worryingly, 23% of children aged 10 to 11 are obese, and 20%, 1 in 5 of all children over the age of 5, are either overweight or obese. Now, if we look at ethnic groups, 70% of black adults are obese or overweight, 65% of white British are obese or overweight, but only 37% of the Chinese population are. And obesity is markedly increased in the most deprived groups of our society. But it is a global and complex health concern. It reduces life expectancy, and it's a significant risk factor in many chronic diseases. And I'm thinking of things like type 2 diabetes here, coronary vascular disease, liver disease, up to 12 types of cancer. And we now think that obesity is the second biggest driving cause in those cancers, respiratory disease, and also mental health. A really depressing statistic is that we as Britons seem to spend more on confectionery every year, just under £4 billion, than on fruit and vegetables, just over £2 billion. Now, the obvious thing to talk about here is BMI, body mass index, which is a really easy, ready reckoner when we're looking at whether someone is obese or overweight, but use it with caution, especially in people with high muscle mass. If you look at athletes such as professional rugby union players, for example, they would technically be described as overweight or obese, although they are extremely fit, highly muscular athletes, because it is not a direct measure of central adiposity. And there are pretty much 5 major classes linked to BMI we should know about. So a healthy weight is a BMI of 18.5 kilograms per metre squared to 24.9. Overweight is 25 to 29.9. And whereas previously obesity just used to be 30 plus, we now have 3 classes of obesity linked to BMI. So obesity class 1 has a BMI of 30 to 34.9. Obesity class 2 is 35 to 39.9, and obesity class 3 is a BMI of 40 and above. Now, an interesting point here is that people with a South Asian, Chinese, other Asian, Middle Eastern, Black African, or Afro-Caribbean family background are more prone to central adiposity, and so their cardiometabolic risk occurs at a lower BMI. So in these groups of people, use lower BMI thresholds as a practical measure to look at if they are overweight or obese. So in those groups of people, overweight is classified as a BMI of 23 to 27.4, and obesity a BMI of 27.5 and above. Now, this is one of the reasons why I'm increasingly looking at a waist-to-height ratio in my patients. So I always encourage adults with a body mass index below 35 to measure their own waist-to-height ratio in order to assess their central adiposity. In other words, the accumulation of excess fat in their abdominal area. And I try to direct them to resources that give advice on how they should best measure their waist circumference, and things like the NHS BMI Healthy Weight Calculator is a useful tool here. But essentially, to measure this, find the bottom of their ribs and the top of the hips, and wrap a tape measure around the waist just above the belly button, before telling them to breathe out naturally and taking the measurement, and measure their waist circumference and their height in the same units. Once you've done that, divide their waist measurement by their height measurement. So, for example, 38 inches divided by 67 inches would give a waist-to-height ratio of 0.57, as would 96.5 centimetres divided by 170 centimetres. Now, we can then look at the degree of central adiposity based on that waist-to-height ratio. And we can look at what's healthy, we can look what's increased, and we look at what's high. So a healthy central adiposity is a waist-to-height ratio of 0.4 to 0.49, and this indicates no increased health risks. Increased central adiposity is a waist-to-height ratio of 0.5 to 0.59, and this indicates increased health risks. Whereas high central adiposity is a waist-to-height ratio of 0.6 or more, which indicates further increased health risks. And these classifications can be used for people with a BMI under 35 of both sexes and all ethnicities, and this includes adults with a high muscle mass, such as athletes like I mentioned before. Now, the health risks associated with the higher levels of central adiposity obviously include things like type 2 diabetes, high blood pressure, and cardiovascular disease. So when you're talking to a person about their waist-to-height ratio, essentially just explain to them they should try to keep their waist to half their height. That's a really nice measure to get home. Keep your waist to half your height. In other words, a waist-to-height ratio of under 0.5. So in practice, if someone presents in front of us in our surgeries who is significantly obese, what should we be doing? Well, there are multiple things to do. Unfortunately, doing them all in a 10-minute consultation can be difficult. But essentially, we're taking measurements to determine the degree of overweight or obesity, and we'd then be looking to discuss the implications of this person's weight with them. So look at things like any possible underlying causes of overweight or obesity. For example, would they have polycystic ovary syndrome? Would they have an underactive thyroid gland? Ask them about their eating behaviours, and do they have any comorbidities such as sleep apnea, hypertension, type 2 diabetes, cardiovascular disease, dyslipidemia? Are there any risk factors assessed using a lipid profile? So we do that, preferably done when fasting. We check their blood pressure measurement, and I always check their HbA1cs as well. Are there any environmental, social, and family factors that may be impacting on their obesity? Are there any psychological problems, medical problems, or medication that may be impacting things? And what about the role of the family and care workers in supporting overweight people with learning disabilities to help make lifestyle changes? There really is a lot to look at, and I'll be talking about these in more detail in Study Group 4 if you're there. Now, referral to Tier 3 weight management services can be considered if the underlying causes of someone's obesity needs to be assessed, or if that person has a complex disease state or need that can't be managed adequately in Tier 2. And a common example here would be the additional support needs of people with learning disabilities, for example. Also consider Tier 3 referral if conventional treatment hasn't worked, or if you're considering drug treatment with a person with a BMI of more than 50. If you're thinking whether specialist interventions, such as a very low-calorie diet, might be needed, or if surgery may be a possibility, then obviously Tier 3 referral should be considered. But in looking at lifestyle and activity changes first rather than rushing to drugs, take into account that person's individual preference and social circumstances, and also their experience and outcome of any previous treatments. Talk to them about their increased health risk based on their waist to height ratio and document results of any discussion. I would suggest you keep a copy of any agreed goals and actions in the notes, and also ensure the patient does this too, and encourage them to increase their level of physical activity even if they don't lose weight as a result. And that's a really important point I'd make here, because of the other health benefits it can bring, for example, reducing the risk of type 2 diabetes and cardiovascular disease. And always advise our patients that in order to prevent obesity, most people will need to do 45 to 60 minutes of moderately intensive activity each day, especially if they don't reduce their energy intake. And advise people who've been living with obesity and have lost weight, they may need to up that to 60 to 90 minutes of activity a day in order to avoid that weight going back on again. Now, dietary advice is such a hot topic in obesity, and the main requirement of any dietary approach to weight loss is obviously that total energy intake should be less than energy expenditure. And diets that have a 600 calorie a day deficit, or that reduce calories by lowering the fat content, low-fat diets essentially, in combination with expert support and intensive follow-up, are recommended for sustainable weight loss. Only consider low-calorie diets, in other words 800 to 1600 calories a day, when others have failed, but do be aware that these are less likely to be nutritionally complete. And I think it's also important to say that we should not routinely be using very low-calorie diets, by which I mean 800 calories a day or less, to manage obesity regularly. In fact, only consider those as part of a multi-component weight management strategy for people who are living with obesity and who have a clinically assessed need to rapidly lose weight. And the obvious example here would be people who need joint replacement surgery or who are seeking fertility services. If you're going to use a very low-calorie diet, then ensure it's nutritionally complete, ensure it's followed for a maximum of 12 weeks, and that any person following such a diet is given ongoing clinical support. Now, drug treatments have obviously come to the fore in recent months and years, and consider pharmacological treatment only after dietary, exercise, and behavioral approaches have been started and evaluated. So consider drug treatment for people who haven't reached their target weight loss or who've reached a plateau on dietary, activity, and behavioral changes. And make the decisions to start drug treatments after discussing any potential benefits and limitations with the patient, including the mode of action, likely adverse effects and monitoring requirements, and the potential impact on that person's motivation. Orlistat, obviously, is commonly prescribed, but only prescribe this as part of an overall plan for managing obesity in adults who meet one of the following criteria: a BMI of 28 or more with associated risk factors, or a BMI of 30 plus. And only continue Orlistat therapy beyond 3 months if the person has lost at least 5% of their initial body weight since starting drug treatment. And the co-prescribing of Orlistat with other drugs aimed at weight reduction is not recommended. Again, I think an important point. Now, in recent months, we have seen a huge surge of interest in the public in glucagon-like peptide-1 receptor agonists. And so I want to look at liraglutide initially as one of these, because this is recommended as an option for managing overweight and obesity alongside a reduced calorie diet and increased physical activity in adults, but only if they've got a BMI of at least 35 or at least 32.5 in the minority ethnic groups I mentioned earlier in the podcast, or if they've got non-diabetic hyperglycemia or a fasting plasma glucose of 5.5 to 6.9. Also, only use them if they've got a high risk of cardiovascular disease based on risk factors such as hypertension or dyslipidemia, and also that it has to be prescribed currently in secondary care by a specialist multidisciplinary Tier 3 weight management service. As with all these GLP-1 receptor agonists, these are subcutaneous injections. Now, semaglutide, also known as Wegovy, is recommended as an option for weight management, including weight loss and weight maintenance, alongside a reduced calorie diet and increased physical activity in adults, but only if it's used for a maximum of 2 years within a specialist weight management service, and that person using that has got at least one related comorbidity and a BMI of at least 35 or a BMI of 30 to 34.9 and meet the criteria for referral to specialist weight management services in NICE's guideline on obesity. And again, use lower BMI thresholds for people from South Asian, Chinese, other Asian, Middle Eastern, Black African or Afro-Caribbean family backgrounds. Now, if you've used semaglutide for at least 6 months, then consider stopping it if less than 5% of the initial weight has been lost after 6 months of treatment. Now, in a slightly confusing way, because semaglutide is also licensed under the brand names Ozempic and Rybelsus, which are recommended by NICE and available on the NHS for managing blood glucose levels in people with type 2 diabetes, it is currently only Wegovy that's recommended for weight management in people with or without type 2 diabetes. So the current advice is that Wegovy is to be made available to people in specialist NHS weight management services who meet the NICE eligibility criteria, or, and this is a slight kicker at the moment, privately through a registered healthcare professional. People who are prescribed Wegovy within these specialist NHS services will also receive support with dietary advice and exercise. And at the time of podcasting, Wegovy can't yet be prescribed outside of specialist weight management services, but the Department of Health are in the middle of a 2-year pilot to tackle obesity, which is going to explore how Wegovy can be prescribed outside of these services. Now, essentially, Wegovy mimics the action of the gut hormone GLP-1 released after eating, and it slows down the movement of food in your gut so people feel fuller for longer. And in the Step 1 clinical trial involving semaglutide, people on the maximum dose of it lost 12% more of their body weight compared to those who were not on the medication. Unfortunately, as you may have been aware, with patients requesting Wegovy, there are significant supply issues, not just in this country, but worldwide. However, there is clinical trial evidence to show that people lose more weight with semaglutide alongside supervised weight management support than with just the support alone, and more weight appears to be lost with semaglutide than with liraglutide. In people with non-diabetic hyperglycemia, semaglutide plus lifestyle measures helps normalize blood glucose more frequently than lifestyle measures alone, and also semaglutide may decrease the risk of cardiovascular disease. Now, contraindications to this type of injectable treatment is if the patient or any of their family have ever had medullary thyroid carcinoma, or if they have multiple endocrine neoplasia syndrome type 2, or obviously have had a serious allergic reaction to a GLP-1 drug in the past. But those are obviously relatively rare conditions. Side effects can be quite significant and can be relatively common. They include nausea, stomach pain, heartburn or belching, dizziness, diarrhea and vomiting, headache, tiredness, runny nose or sore throat, and constipation. And it is important to note that they may worsen diabetic retinopathy. So if you have someone who you know has diabetic retinopathy and they start an injectable treatment such as Wegovy, always tell them to report any alterations to their vision sooner rather than later. One of the problems that we're seeing, though, is there is now a very significant black market in injectable drugs purporting to be Wegovy when they are actually fake, and celebrity endorsements with very well-known people across the globe are adding fuel to that fire. So this is a problem which is not going to go away, and we have to really watch this space with some interest as to what happens here. But I do hope you've found that podcast helpful, and it's given you a bit of a refresher about what we should be doing with our increasing numbers of overweight and obese patients. But do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and to download free shortcuts to help improve the lives of our patients in primary care. But as always, thank you for listening, and until the next time, goodbye.